And we are recording this meeting, and we will be sending out the slides to everyone as well. So I think I know most people on the call, but wanted to welcome everyone and introduce myself, and then introduce a new team member of the Colorado Cancer Screening Program as well. So I'm Elsa Weltzine. I'm the Senior Program Manager for CCSP. And I'd love for everyone to put in the chat to introduce themselves as well, your name, your role, and what clinic system you're with, especially to introduce to our new team member, who I'll have introduce herself in just a moment. So just as an announcement to all our current partners with CCSP, Rena Solar, our program coordinator, has transitioned on as of the end of June. So now I'm really excited to introduce our new patient navigator manager, Wesley Lighthall, who has many years of experience in the cancer prevention field in a couple of different organizations in Colorado. And we're really excited to have her on our team now half-time to really assist with the technical assistance, training, and programming for CCSP. So as you all introduce yourselves to her in the chat, I'm going to turn it over to Wesley to introduce herself, share a little bit about her background and her current role with CCSP.
Great. Thank you, Elsa. As Elsa said, I'm Wesley Lighthall. I'm the new Patient Navigator Program Manager with CCSP, started July 1st. I have been working in colorectal cancer prevention since about 2015, previously with CDPHE and some of their clinic quality improvement projects. So may have worked with some of you before, or at least with different health systems and organizations through that work at the state. And then some experience doing process improvement work at Children's Hospital Colorado. So really been doing a lot of quality improvement, cancer prevention work throughout my career for the past decade. So I'm really looking forward to working with all of you and reaching out in the next few weeks to have individual clinic check-ins and learn more about what you do and help support the program in different training and technical assistance needs.
Thanks so much, Wesley. And we're really excited to have her on the team. And thanks so much, everyone who's introducing yourselves in the chat. Great to see our partners from all across the state. So I want to give a shout out to all of those from Valleywide joining us from the San Luis Valley and Arkansas Valley Peak Memorial out on the Eastern Plains. Salute our partners at Bringer Caritas in Denver, Pueblo, Peak Vista, and Colorado Springs, and many more. So thank you, everyone. Really excited to have you all here today. And I have just started sharing my screen. And so I'm going to jump right into our agenda for today to make sure we're on track. So the first portion of the call, we're really going to be focused on the new application for the Cancer Cardiovascular and Pulmonary Disease Grants Program, which is how CCSP has been funded since the start of the program back in 2006, 2007. And then we're going to go over what's in that RFA, how it relates to cancer work and CCSP, and the opportunity for CCSP to apply, and looking to continue to engage clinic systems for participation. So we welcomed both current clinic systems involved with CCSP to this monthly call, as well as those that might not currently but be participating in CCSP but are interested in engaging for the new grant cycle. And then the second half of the call, we want to transition into sharing some program updates about this next current year of the grant cycle, the last year of the current grant cycle that just started in July. And then if time allows, I want to share a few highlights from our data from last year's grant cycle, or last FY22, the last year that just ended at the end of June. So Andy is still technically on maternity leave, our program director, but she's here today as well to help share a little bit about the RFA and opportunity for everyone to engage. So I'm going to turn it over to Andy to introduce what's in the RFA and the opportunities for CCSP.
All right, awesome. Hey, thanks, Elsa, and everyone. And yes, I'm on maternity leave, so I'm going to be super quick today because I have an infant who's being a little squirmy. So he was born June 1st. We were expecting him July 4th, so a little bit early, but he's doing really well. And thanks for all the notes and the support from everyone. And so we are super excited about the continuation of CCSP for this next year. We still have the money for the navigation, all the work, the support. We did very well this year, meeting our goals. Elsa's going to talk a little bit about those outcomes. We did have some of the resources go back to CDPHE, about $60,000 worth of the over $750,000 grant. That we had some reserve left for our navigation allocation. So I just want to say, as we get ready to start this year, your allocations, knowing how many people you're going to screen, if there's furloughs, any transition in staff that are going to help with reduction in the number of navigation or lead to that sort of work. We'll just want to try to keep some good tabs on that. So hopefully next year we give no money back to CDPHE, but we still did meet most of our goals, and you guys have done an amazing job with almost the last 20 years of the grant. What we're going to be doing is focusing on a lot of work around evidence-based interventions related to provider patient engagement, consistent with what the RFA is looking for. So the next RFA will start in July of 2023. So our current grant will sunset June of 2023. So the grant that we're going to be responding to with CCPD right now, with a due date of September 15th, we are really in the midst of looking at an approach to respond to this evidence-based intervention engagement with our health centers, safety net, rural health clinics. So we're really excited about working with all of you in the continuation of this grant. As also noted, the CCPD team did come out with specific recommendations. In cancer, there's 3 areas: colorectal, looking at also HPV vaccination and lung work. The university in the cancer center work, we are going to continue to really focus on RFA to the colorectal cancer engagement through CCSP. So around those evidence-based interventions that I mentioned around patient and provider engagement, those are going to be the areas that we really spend our most of our time and engagement with all of you. We're really going to be looking at a focus on rural and frontier communities, but also those of you who are serving communities of color, which is most everyone on this call. So we are going to be setting up discussion points for each one of the clinic sites about the new RFA, how that supports the increase of stool-based testing, referrals and completion of colonoscopic exams, navigation to a certain extent, but also the overall evidence-based interventions that we know that drive screening, and how navigation and provider engagement is going to really increase those rates. So we're coming up with our strategy, our plan. We're going to be working with CCHN, Colorado Rural Health Center, American Cancer Society, our Cancer Coalition, and as Wesley noted and Nelson noted, when we have those one-on-one calls that we're setting up with each of you, we'll also be talking about this RFA. The RFA came out a little faster than we had anticipated with the due date, much quicker than we anticipated. So again, the formal due date is September 15th, but we need to have our application in full working order by early September to be consistent with circulation through the university system. So again, those interventions are going to be driving the work that we're thinking of, but we're also going to be really looking at what are those areas of Colorado where we've seen lower screening rates in rural frontier, as well as the community of color, to help really think about where we're putting a lot of our resources, a lot of our engagement, and that of course implies all of you will be involved in that process as well. The one thing I would also say is that one thing we're going to probably yield to is the Colorado Cancer or the Colorectal Cancer Control Program out of CDPHE funded by CDC is also in full play in Colorado. So we also will be thinking about how we complement but not duplicate that current application as well. So again, really excited about this work. If you have some specific questions, if you've been looking at the RFA, you and your team want to talk sooner than later, let us know. I'm going to be really relying on our team, Wesley, Elsa, Betsy Risendahl, to help with this application because I am in the midst of maternity leave, but we already have a strong footing on the partnerships and getting the application together as well. So I'm going to pause there. And then knowing that I'm having a kiddo that might be screaming here momentarily, Elsa, Wesley, I'll have you fill in any of the other details. And I think let's leave a little bit of time for questions about the RFA as well. The only thing I want to just mention though is the RFA is different than what they have put out previous. So although we will engage navigators, navigation will still remain a big focus of what we do at the Cancer Center, the work we do with all of you. We're going to be looking at strong intervention work from the entire team with provider engagement, as well as where the role of navigation too. But the navigation is not the primary driver. It's really looking at the overall approach to looking at those systems change and overall, what does it mean for team-based care to drive screening rates with stool-based testing, as well as what are we going to be doing with referral and highest utilization and maximization of endoscopic and colonoscopic screening. So Elsa, anything else that you'd like to share? And you can go into some of these details as well.
Sure. Thanks, Andy, for that overview and really what the mission and purpose of this RFA with the opportunity for how CCSP can continue the work. So what I have listed on this slide are the particular evidence-based interventions that CCPD is really looking for focus for the colorectal cancer screening work. And those are increased use of provider reminder and recall systems, increased use of standing orders by healthcare providers, increased provider assessment and feedback, client reminders for screenings, and provision of cultural competency training for healthcare providers to promote health equity. So CCSP is going to provide opportunity for clinic systems to receive support to implement any of these, and looking for clinic systems who are interested in participating to choose 2 EBIs that they really want to focus their work around and improvement. And so that still allows for concentration on other EBIs related to colorectal cancer screening, but looking to enhance about 2 more of these. And so even though some of these really are provider focused, as we know, it really does take a whole team-based approach. And so there's opportunities for navigation to weave in all of these, I think, and especially, of course, around those client reminders. And so we are really thinking about how this approach will look. It won't really be a fee for service approach like we have done for the colonoscopy navigation, but just based on the level of work and the types of EBIs that clinic systems would like to focus on and what their goals are, we'll be providing instead larger payments, looking around $20,000 or more for clinic systems to really receive support and training and technical assistance from CCSP and our community organization partners. So for clinics that are federally qualified health centers, we're looking to work directly with CCHN to work in partnership to provide that training and technical assistance to help meet those EBI goals and receive coaching. And then for clinic systems that are rural health clinics, working directly with the Colorado Rural Health Center, and then the American Cancer Society, providing opportunity for some collaborations and learning collaboratives. So everyone will have the opportunity, of course, as well to come together and learn from one another, in addition to just receiving one-on-one support from CCSP. So that's a pretty broad strokes overview of what this grant cycle is shaping up to be. But we are right now looking to get interest and engagement from 10 to 20 clinic systems that would be interested in participating if we receive this funding and our application is approved. And so the priority, of course, would be for clinic systems that are in those areas with lower screening rates or higher incidence and late stage incidence and mortality in those rural areas. So there is the opportunity for clinic systems who haven't felt like the evaluation or navigation requirements in the current grant cycle fit with their capacity, but that opportunity to reshape a little bit of the structure while integrating the foundation of CCSP to really improve screening rates in a little bit of a new and different way than we have previously with the program. So we're reaching out a little bit to get clinic systems interest, but would welcome all of you to reach out to us directly to let us know if you're interested in engaging. We'd like to set up a call to discuss what that could look like, in particular, what EBIs are of interest to you. And then we are looking for letters of support for the application, which we can provide templates, but that is the requirement for the application, to have letters of support from all of our partners who are engaging. So I'm going to stop there. That was a lot of information, and see what questions you all have about the RFA and what it looks like. And you're welcome to come off mute as well.
Also, I do think it's probably important to note, in the RFA, I initially was wondering if it would be helpful for clinic systems to independently apply. Would it be helpful for the university to continue through the infrastructure of CCSP? And one of the things that I think is interesting is that the lowest amount is for $100,000. So I do think a support through CCSP approach is still the best way for us to go for technical assistance management to build off the great work that we have. I know for clinic systems to manage a grant like this, or even at that base amount, it can be pretty complex. But we did really think a little bit about what would be most advantageous, given that what's focused on in the cancer realm. So the other thing I just want to mention is we will, of course, be focusing on colorectal cancer through the CCPD application, but we will be looking at other funding to continue the work for the hereditary and lung cancer screening work. We don't want to lose what we've been able to foster in terms of the capacity work. So FYI, we'll still keep that on the radar. Navigation is still going to be a key part of what really drives this application, as well as the additional work. But the other thing is that there are 2 additional areas for cancer screening work, or excuse me, cancer work with HPV vaccination. And then through the university, we are looking at helping with an application through some of our colleagues at the university for the lung cancer component, which is really looking at an assessment of what's happening in lung cancer screening. So I just want to remind everybody there's multiple opportunities through that RFA, but that dollar amount is about $100,000 low threshold. So there's not an upper limit, but you have to ask for at least 100,000 to be able to submit. So I think we're in good shape as our infrastructure and as a network grant to put something forward. But we will continue to keep an eye on the other areas where we have been focusing our cancer prevention work.
Yes, those are really important points of how we're focusing just on the CRC work directly with CCSP. It really just was the way it was shaped this year for this cycle, that each of the different cancer types kind of fit under different paths, and we're only able to apply for one path. So really focusing CCSP on the CRC screening work, but really wanting to continue to support clinics with their overall cancer screening efforts, including in lung and hereditary, which we've worked so hard in this current grant cycle to really move the needle towards wider implementation, as well as patient navigation. And so the one other piece for the patient navigation and thinking about sustainability and reimbursement for navigation, that is an opportunity that's through the policy path, really looking at payer coverage and sustainability of the navigation workforce. But that's something that another group is probably going to be applying for. So they will be really trying to see if they have that opportunity to work towards reimbursement models in Colorado for navigation. So that work is continuing, even though it's not directly through CCSP or our application.
The only other thing I wanted to mention is in terms of the application that we are going to be putting together, Elsa really gave a nice overview or even some further description about the evidence-based interventions. One of the things that I think will be exciting about this work is we will have an opportunity to work with systems around which EBIs they're most interested, where you'd like to focus work for specific populations, as well as how would you really like to look at approaches to either stool-based screening or furthering capacity for endoscopy. So what I want to say is that this is a not one size fits all. I do think that the approach we're talking about with the implementation of those EBIs with partners, learning tools, resources, give an opportunity to really focus on the areas that you want. But it really can be tailored to what you need to do to drive screening rates for colorectal cancer within your organization. So we're excited about moving this forward. I do think it adds a little more of a dimension to CCSP, building off of what we've been able to accomplish based on all the great work of all of you who have been part of this program for a good period of time.
And I am really excited that it does allow for more fluidity in which roles from the clinic systems are directly involved with the work. So the opportunity to utilize MAs, nurses, the navigators and providers, all with that focus on the work happening. With right now, we know that all of those roles are part of that team-based care approach, but our focus really being more around the navigation. So now with this new RFA, really allowing those roles to fully be integrated into workflows, making sure each piece is captured and who's doing what to the best of their role and how it fits with the overall clinic team. Okay, well, I haven't seen any questions come in yet, but if you do have any, please feel free to put them in the chat as we continue, or send us an email afterwards. And again, well, please let us know if your clinic system is interested in engaging, and we are working on setting up calls with clinic systems as well to kind of talk one-on-one about this current grant year, so FY23 that just started, as well as the RFA, moving as quickly as possible. And we're really excited about the opportunity to work with you all again going forward, and making sure that there is this continued support for colorectal cancer screening work because it is so needed. Andy, anything else before I move on to FY23 and our data from FY22?
No, you covered it nicely and we're excited.
Great. Well, thanks so much for making the time as well, Andy. And we're working around her schedule, but definitely the whole team is involved in pulling together this RFA. So really excited about putting together an application that can best support clinics. So we do, though, have a whole year left of the current CCSP structure, and we're really that we've kicked off this new year. So FY23 just started a month ago on July 1st. And as we mentioned previously, will run through June 30th, 2023, not 2022. But if CCSP does receive funding from the new RFA, it would continue on without a pause with the new grant cycle starting on July 1st, 2023. But either way, we still have this full year left of funding for the current grant cycle and the current structure that it is now. So yesterday, I sent out an email to all clinic team primary contacts with a summary of your numbers and evaluation data for the colonoscopy navigation. If you are focusing on that strategy for CCSP with your data, how many allocations you were able to use last year for patients successfully navigated in the colonoscopy, and then what we're able to provide as a baseline number of allocations for FY23. So all clinic systems are receiving a slight bump in their allocations from what they were able to use for screening in FY22. But since this is the last year of the current grant cycle, and knowing that we come down to the wire with making sure we have all the data and invoices, and really wanting to show the health department that we are reaching our goals with screening, since we were a little bit under our goal for the colonoscopy work in FY22. We really want to encourage clinic systems to aim to reach your total allocations for colonoscopy navigation by the end of May 2023. So if you able to use all of those allocations by mid-spring, we can look at opportunities to bump up a little bit further, but really want to encourage clinics to get going on getting patients navigated into colonoscopy, understanding, of course, that there are still challenges in workforce and outside referrals. But if you're able to look at what those barriers are, let us know, and we're happy to provide support as we're able to in trying to think through how we can overcome some of those challenges. But really want to encourage clinics to get all of their patients who are eligible on that navigation path into colonoscopy and utilize and reach our goal of 2,750 colonoscopies for this year. I also want to remind clinics that we still have a budget for barrier reduction. So we're able to reimburse clinics for patient services for transportation, purchasing bowel prep supplies, interpretation, hotel if you're in a rural area and patients have a long drive to get their colonoscopy, or if working with unhoused populations and needing a safe place to do their prep. So as always, we're able to reimburse the clinic directly, but not the patient. But we're requesting that you let us know how much barrier reduction funding you think would be helpful for this year, how much you could realistically utilize. So please send an email to myself and Andy of how much money you're looking to utilize and request for barrier reduction for this year as soon as possible. But by September 15th with an estimate would be really helpful. Evaluation reports for the colonoscopy navigation continue to be due on the 10th of the month in Qualtrics. Please note that there is a new link for Qualtrics for FY23. The questions and metrics are all exactly the same as they were for FY22, but it's a new survey link. And I've also sent all clinic teams a copy of the template for the colonoscopy navigation tracking with all of the data metrics for CCSP. So please let me know if you didn't receive that information. I'll be resending it in the follow-up as well. And then please continue to send your monthly invoices to Barbara and Kelly from our CU Cancer Center finance team, and please CC me as well. Helps with our internal tracking and to make sure if there are any misses that they get to our team for reimbursement and processing. And so we will be providing the opportunity for all clinics also to continue their capacity building projects for stool-based testing, hereditary cancer risk assessment, and lung cancer screening in FY23. So as we're setting up one-on-one calls for the launch of FY23 with each clinic system, we'll be wanting to talk about how you would update your goal from what you accomplished in FY22 to continue to build upon that momentum in FY23 and reach more patients. So we will be providing another round of funding as well, and we'll review what's available for that on those calls, but start thinking about what would be another goal if you are participating in that work that could be achieved by June 2023. So Wesley is going, as she mentioned, is going to be taking the lead in scheduling one-on-one calls with each clinic team. So looking to get those scheduled over the next month. Some clinic systems we've already reached out to, and if you haven't gotten a note yet about setting up a call, you will in the next couple of weeks. And so we will be talking about the RFA, making sure we have an updated contact list for your navigators and other primary team members that are directly involved in CCSP work, reviewing your allocations and how we can support your colonoscopy navigation work, that capacity building work if you are participating in that. And since this is the last year of the current structure of CCSP, making sure that you all have support to continue to sustain the navigator role as well, whatever the next years look like for your cancer screening work. So, and then keep an eye out for upcoming trainings for FY23 and programming opportunities for navigators and others in your team around the focus areas of CCSP. So as it's frequently requested, and we always do get some more team members from each of these our clinic systems, we will be hosting a CCSP 101 in October. So the calendar invite for that will be sent out very soon. And then we have reviewed all of your feedback from the end of the year survey, where you provided some additional thoughts around topics for trainings and technical assistance sessions in FY23. So let us know, please, what other types of sessions, presentations, webinars, or in person would be helpful for your team this year. And that can include for your providers as well as your navigators. So I'm just going to make sure I didn't miss anything in the chat. And if you do have any questions about the information we reviewed for either the RFA or what's to come this year, yeah, please feel free to drop those in the chat at any time or stop me. But I do want to just share a little bit about for FY22, now that we have all of the data from this last year. And thanks so much to everyone who was involved with pulling your final information for the year around the colonoscopy navigation work, as well as the lung, the family history, and the stool-based testing work. We got great feedback from CCPD. They were really happy to see all of the work happening in stool-based testing, how many patients have already been reached just between that initial period of capacity building from January to June. And yes, just really excited to see how we're able to reach more patients beyond just with colonoscopy. And just wanted to share a couple of highlights from our FY22 data. So I know it was a challenging year with workforce shortages, some staffing challenges, both within the our clinics, you all with your teams working so hard, as well as with those specialty care clinics you work closely with. So just want to say, even though we didn't reach our colonoscopy navigation goals, we have really been able to reach so many patients, and it would have not been possible with all of your hard work to get patients into their cancer screening, with COVID continuing on and the new challenges that continue to bring. So there were 2,286 CCSP eligible patients that received a colonoscopy in FY22, and additionally 2,147 stool tests administered between January and June, and that was just from the paid clinic systems that are participating in that stool testing capacity building opportunity. But we know that many additional stool tests have also been administered to patients from CCSP clinic systems. And so far, as of the end of June, 991 of those stool tests were completed, and that doesn't include 2 of the capacity building sites that did not yet have that data available. For our lung cancer screening work, want to give a big congratulations to Bruner Caritas, who was able to reach more patients than ever before for lung cancer screening navigation than any of the previous years so far in this grant cycle. So there are 113 clinic systems that completed a shared decision-making visit at Bruner Caritas, and 49 of those patients were able to complete a lung cancer screening low-dose CT by the end of FY22, so the end of June, but knowing more of those patients are still being navigated into an appointment, and really excited as more clinic systems are starting to work on lung cancer screening, the opportunity for Bruner Caritas to share some of their lessons learned. So we'll definitely incorporate some of the things that have worked well and been challenges that they've overcome, as well as we're supporting some of the new clinic systems that are just starting this work. But really exciting to see how much growth has happened at Bruner Caritas over the last 3 years. And then there were 3 clinic systems who were able to establish new workflows for hereditary cancer risk assessment, utilizing Ambry Genetics chatbot for the risk assessment and their telehealth genetic counseling and testing. So Denver Health, Keith Memorial, and Uncompadre. So a lot that we'll be able to share about how that's going as it continues to grow and implementation begins. But Denver Health was able to get that risk assessment chatbot sent out to a first handful of patients in June. So lots more to come with that shortly. Since the colonoscopy navigation data is where we collect the most information about outcomes and demographics, I do want to share just the highlights from the overall program on patients reached this year. And then I have sent each clinic system their individual data where you can compare from the last 3 years of the grant cycle to FY22. What's been changing in patients reached, number of completed colonoscopies, and so on. And if you're not currently participating in the colonoscopy navigation work, can reflect on how these demographics and patients reach compare to your stool-based testing population. So there were 2,456 total patients reported as successfully navigated into colonoscopy, and that includes both those that do meet the CCSP eligibility criteria and those that are not CCSP eligible. And then our total number of patients that are CCSP eligible that completed a colonoscopy was 2,286. With our goal of 2,750. But even though we didn't reach that goal, we had a smaller number of clinics participating in CCSP than the year before. And over half of clinic systems were able to increase their number of colonoscopies from the year before. So even though we didn't reach our goal, many clinic systems were able to exceed their previous goals and totals. And we did have a reported 188 cancellations, which is a 7.5% cancellation rate, and just 32 no-shows reported, which is 1.3%. However, we have seen less clinics able to repeat or able to report their no-shows. So even though that is a really important indicator of navigation, knowing that there has been changes in capacity, this number right now I think is a little bit underreported, but it's still always great to see that CCSP has always maintained a rate of 10% or less. So I think even though this is underreported, we likely still are around that 10% or less rate for no-shows. And then there were many patients that were referred to services with WWC and CPED, knowing that many patients are eligible and navigators are working with them for both breast and colorectal or breast, cervical, and colorectal cancer screening. And then for demographics of patients reached and the outcomes, we're still on track with reaching similar levels of men and women, knowing that colorectal cancer affects both equally, although men continue to be a little harder to get screened, but great to see that it's similar levels. Now that the screening guidelines have been lowered to 45 to starting at age 45 instead of 50, CCSP clinics were able to have 10% of the colonoscopies that were completed occur within patients among that age range, and that has been growing since we started tracking that data 2 years ago. And then still continuing to reach those that are between 50 and 75, but also seeing an increase in patients getting colonoscopies younger than 44 because of signs or symptoms or a family history risk of colorectal cancer. So with the increasing rates of colorectal cancer in patients under 50, still really important to get patients into colonoscopy if they have that family history or are experiencing signs and symptoms at an earlier age. And CCSP does reimburse for that colonoscopy navigation if the patient is under 45, as long as they either are experiencing signs or symptoms or have a family history. And CCSP clinics were able to reach 42% of the colonoscopies were performed in patients who identify as Hispanic, 3% Asian Americans, 6% Black Americans, and 1% identified as another race or ethnicity. And then still over 50% being patients that have Medicaid or Medicare, and then 13% uninsured. But no, we do acknowledge, of course, that is still the biggest challenge in getting accessible colonoscopy for uninsured and undocumented patients. So even though that's not resources that CCSP currently has, please know that we've been working closely with the health department on the links of care opportunities to try to find sources of low or no cost colonoscopy for patients who really need it. So that work is still continuing on, and we'll provide updates as soon as we learn anything more. 43% of patients were getting a colonoscopy for screening, but more and more each year we're seeing that patients are getting colonoscopy for surveillance from another abnormal finding. or because of their family history, as well as if they need a diagnostic colonoscopy because of signs or symptoms or a positive FIT or FOBT, so, or Cologuard test. So it is up to you all how it's best to allocate your colonoscopies, whether that's primarily as follow-up for stool-based testing, or if your providers still continue to want to utilize colonoscopy with average risk patients or up to patient choice. But that's something we'll be continuing to focus on in the next year, as well as this next RFA, how we best utilize stool-based testing versus colonoscopy to get the most patients screened, because the best test, as we like to say, is the one that gets done and gets done well. Prep quality was still really high at 93% of patients reported to have an adequate bowel prep, really demonstrating the great work of all of you navigators in providing education to patients, but seeing in some colonoscopies not seeing what that prep quality was on the report. So we'll continue to review that in our CCSP 101, how you pull that information out of the endoscopy reports, as well as 97% complete exams. So even if the bowel prep rate wasn't adequate, being strong enough that the whole exam was able to be completed up till the cecum. And last measure we look at is those outcomes of the colonoscopies. So in 45% of colonoscopies, there were no polyps detected. However, having over 50% of a polyp or cancer detection is quite on track with what we expect to see from the literature. The most common types of polyps, according to our risk categories that were developed by our medical advisory team, are precancerous polyps, and that is consistent with what we should expect to see with advanced or high risk being between that 5 to 10%. I know some clinic systems are seeing a larger amount of benign polyps, so I really want to encourage clinics to utilize that chart of the different polyp categories and making sure they match the definitions. And there were 23 cancers detected from CCSP eligible patients this year, so a 1% cancer detection rate, which is what we've seen across all years of this grant cycle. So just wanting to give everyone great kudos in being able to reach those patients in need, especially reaching those that are underserved, and really strong outcomes in terms of prep quality and complete exams. There are just a couple of notes I wanted to share about how we can continue to improve the quality of our colonoscopy navigation data. So we did share those patient level tracking templates in Excel that you can use to track your patient level data before you put it into Qualtrics. We encourage you to please use those all throughout the year. So when we come to audit time, it's really easy to make sure that data is complete, matches what's been submitted into Qualtrics, and it does automatically sum the data for you as well. So it should be a simple task of just pulling those aggregate levels into your Qualtrics report each month. And just want to remind everyone that if a patient did complete their colonoscopy and they're CCSP eligible, those are the only patients we need that demographic and outcomes data. And that same number of patients that were reported in Qualtrics should be the same number of patients that is reported on your invoice each month as the patients that successfully completed their colonoscopy. So please don't include any patients that were no-shows or cancellations on your invoice, and make sure you're please including all patients in Qualtrics that are also invoiced for. we want to make sure that we're paying you for every patient that's CCSP eligible that completes their colonoscopy. And just as a reminder for some semantics on the form, the total patients navigated is the same as all patients who were successfully navigated into their colonoscopy. So for that first question around total patients navigated, that doesn't include any cancellations or no-shows. And if you are only reporting for CCSP eligible patients, the overall total should be same as your total CCSP eligible patients. But if you are also navigating patients that are not CCSP eligible, that's when that total number might be a few more than your number of CCSP eligible patients successfully navigated. And looking at those endoscopy and pathology reports for bowel prep quality, as well as whether the cecum was reached, making sure that you're clear on how the providers you work with report that those outcomes is really important. So, for example, the cecum being reached as a complete exam where the scope was advanced fully throughout the whole colon. The cecum reached could include language around the cecum, the scope was advanced to the ileocecal valve or the terminal ileum. So if you're reporting that there's not always that information available, sometimes it might just be that they're using a different term. So getting familiar with how it's reported on your provider's endoscopy reports is really helpful for making sure we have that complete information, as well as for the colonoscopy outcomes, making sure it aligns with that polyp categorization guide. So polyp size, whether or not they're bigger, smaller than 1 centimeter, and the presence of dysplasia can change how high risk or advanced the polyp is. So benign polyps are should be less commonly reported than precancerous. And so making sure you're familiar with those specific polyp types that fit under each of those categories is really helpful to making sure that data is accurate. And then finally, if we can support you all with better reporting of no-shows and cancellations, looking at how some of those clinics that are able to report that data easily do it. If that's been a challenge for your clinic in reporting no-shows, please let us know and we can try to support you all in tracking that data. It is really helpful to demonstrate the full scope of navigation services and how it impacts patient outcomes. So more to come on some of those tips and tricks for data reporting on our annual CCSP 101 webinar, which will be mid-October. But please let me know if you have any questions as you're starting your reporting for this new fiscal year. Any challenges that have come up, any things you're still not sure of, and especially if you're a little bit new to the data reporting, happy to help. But really, really excited to see how many patients were reached in FY22. So just want to give a huge round of applause to every single member of each of the clinic's teams that were involved in this work. The health department continues to have us as one of the model programs that has really strong data, as well as we have many external partners that are always looking to us for lessons learned, and we really want to share about your individual experiences. So please let us know if there's anything we can do to support, or if you need any data from CCSP from earlier years as you're doing internal quality improvement work as well. So that is everything I have for today, but want to take a moment and see if anyone has any reflections, thoughts, questions about last year with CCSP and as we're starting our new year for CCSP. All right. Well, since we haven't all been together in quite a while as well, I do want to just let you all know that we have seen the feedback about everyone getting together for an opportunity for an in-person workshop or annual meeting for FY23. So that is in the works, and really hoping that we can see all of you in person in the next year, come together and celebrate all of the great work that's happened over this current grant cycle. So we're putting together something fun for probably in the spring, but really hoping that we can all come together to celebrate all of your hard work over the next year. Really excited about all of the work still to happen in FY23. And please let us know how we can best support you as we're launching into this first quarter. So thank you all. That's all we had for today. I'll send a follow-up email with these slides and notes, and I hope you all have a great rest of your Tuesday. Thank you.